Well, we are so excited to join you to talk about the option trial today. I'm Megan Coylewright. I'm an interventional cardiologist, and I have my good friend Cara Pellegrini with me today, an electrophysiologist. And this conversation actually came out of a very spontaneous conversation between the two of us about how we were going to think about this new data. Both of us as left atrial appendage operators and really interested in making sure we address some of the unmet needs in our communities. So thanks for joining me, Cara, for this conversation.
It's my pleasure. I'm really excited.
And we join you from two very different areas of the country. So you can see out my window, it's cold and snowy in Minnesota, and she's where it is fairly warm in San Francisco. And both of us busy clinicians and researchers, and most of all, passionate about making sure that we understand how to apply some of the latest evidence. So today we're going to talk about the option trial. And I would be really interested to hear from you, Cara, about what is the buzz in the electrophysiology community?
Yeah, thanks, Megan. I think that there's a real diversity of opinions on the option trial. I think that many people in academia are kind of giving a bit of a shrug that, hey, this is nothing new. We already have this option of doing Watchman or some other left atrial appendage occlusion for patients who need it. And this trial still doesn't really show anything new in terms of superiority. At the same time, I think there's a good number of electrophysiologists out there that are having a lot of patients come to their door concerned about nuisance bleeding or non severe but clinically relevant bleeding and really see Watchman as an option for these patients and are kind of excited about the increased data for safety of doing these two procedures concomitantly. So I would say there's really a breadth of opinions around this trial.
Well, Carrie, you just mentioned a lot of things that the trial looks at. And I think for those of us in the interventional community in general, cardiology, we are a little bit confused about what was the purpose of the study. Was it specifically to look at concomitant procedures? Or we noticed that the patients that were included actually hadn't had major bleeding before. So they were different than the patients who are currently offered left atrial appendage occlusion. In your mind, what was the most powerful piece of that, or is it somehow the combo as it relates to maybe reduced stroke after ablation?
Yeah. So I think there's a lot of interesting things going on here. I think the authors themselves were motivated to think about how we go about reducing stroke risk after ablation. I think that ablation really is something that we're thinking about more and more for people with atrial fibrillation. And there's a growing body of literature to suggest that ablation in and of itself may lower stroke rate. At the same time, after ablation, our AF burden also goes down. And so the question is for a certain subset of patients who have a low enough stroke rate at baseline based on something like a CHADS VAS score or some sort of score risk stratification, and then undergo ablation, what would a left atrial appendage occlusion device look like in comparison to just continuing on anticoagulation for these patients? So, to my mind, the main motivation for this trial was thinking about these patients who undergo ablation and what options do we have to offer them that's most patient-centric. So that's what I was taking as the biggest take-home message from this trial. I think you're right that with each trial that we get in this space, we continue to think more broadly, perhaps, about who might be candidates for this procedure. And so I think that that's a second element worth pointing out.
I really like that answer because it actually was focused more on getting at things that are important to the patients and less about how can we move patients through healthcare quickly by combining a lot of things. That said, do you have a strong feeling about whether patients have a desire to have both of these things completed at the same time based on feedback from patients in your practice?
Yeah, I think that's a great question. And I think it depends a little bit on the practice environment that you're in. for me, I have a lot of patients that travel a great distance to come to me to get this procedure, as I work at a VA center where patients are traveling from 3, 4, 5, or more hours. And so I do have a good number of patients who like the idea of having just one procedure and kind of getting everything done. That being said, there are some potential disadvantages to doing both procedures at the same time. And I want to point out that in the option trial, the vast majority of these patients had paroxysmal atrial fibrillation and were having a relatively straightforward pulmonary vein isolation procedure. So these weren't necessarily patients who had very complex atrial flutters or who were going to be having a lot of additional work in the left atrium. So I think it's important to think about, you know, who the patients that were going into this trial were.
I'm going to ask you now a really challenging question, and that's about real world application of this data. So, Cara and I actually met when I was serving as a proctor with her. She's now a very experienced left atrial appendage operator, but hasn't always been. And now there's a lot of electrophysiologists that might think, I'm going to add this in quickly to my practice. How do you think, if that's the case, we can think about still having specialists in left atrial appendage occlusion for some of the most complex cases? Do you think there will be a space for that? Do you think that we'll see a lot of electrophysiologists kind of adding it in as they go? Or how will this be implemented if there's going to be a big increase in the number of operators who are doing LAO?
Yeah, I think that's a great question, Megan. And I just want to say that that to any people who are thinking about starting a Watchman program, I really appreciated having Megan come, and Dr. Doshi came as well at a different point in time. And I just want to do a shout out that I think learning from our peers and our colleagues is a great way to really be thinking about patient safety as we're rolling out new things. And I think for many of us, perhaps who don't practice in a pure academic center or with multiple partners, don't forget that there are other ways to learn and bring new things into your practice. But getting back to your question about, how would we roll this out? If a larger number of operators are interested in incorporating left atrial appendage occlusion into their practice. I think it's important to be selective when starting a new procedure and think about doing it for easier cases. So to my mind, it would make sense to start by doing a left atrial appendage occlusion procedure on its own, so you can really be fresh and focused and get some repetitions of doing that procedure multiple times in a day over several days before trying to incorporate it as part of a hybrid procedure. That would be the way that I personally would approach it in kind of a stepwise fashion. I think something that I personally have been working on in our practice is doing these procedures with ICE guidance as opposed to TEE, which is another learning leap that, again, I think is very patient-centric, as when you get to the point of being able to do these procedures with ICE guidance, I think it's a little bit easier to not have necessarily the same level of sedation, make it a little bit easier for same-day discharge. And I think by doing this procedure with ICE guidance, it's a little bit easier to fold it into an AF hybrid procedure, as we may not have our echo imaging colleagues available for such a long procedure. And so I think that building some skills with left atrial appendage occlusion as a standalone procedure, and potentially building the skill of doing that even with ICE guidance, then makes it easier to fold that procedure in to select patients as a hybrid procedure.
I agree. As a structural interventionalist, I love to bring proctors into our hospital because there's just an ability to learn so many new strategies. And, when I came to visit you, having that time where I can just dedicate time for teaching and be there, I think is really fun. But you and I obviously are talking about the option trial, and we're excited about the results, and we're talking about how it can change practice. But now I want to actually pull up the results in a slide and look at it with you and ask the question, is this data enough? Enough to really change either the fact that we might add this procedure in with ablation, or if we might think about that it could potentially expand the indication of left atrial appendage occlusion for patients who have not had prior bleeding or high risk of bleeding, but have a strong preference to avoid anticoagulants. Or said another way, a high risk for non-adherence to oral anticoagulants. So I'm gonna pull up one of the data slides. So this was the primary efficacy endpoint, and it looked at a composite of death from any cause, which turned out to be one of the leading outcomes, not necessarily related to the procedure or the device, stroke or systemic embolism, the latter two of which we really hope to be preventing for sure, with whichever strategy we pick. And this particular outcome was powered for non-inferiority. And what we saw was that the two arms are pretty similar, and not over a tremendously short time, over 3 years. Typically, when we're looking at anticoagulation studies over 3 years, we see a lot of people stop their meds. So that's an interesting thing to think about in the background. So what are your thoughts about this as an outcome? And I want you to share your thoughts as an individual physician and what the chatter has been amongst electrophysiologists. And then I'll share a little bit from my side from the interventional cardiologists.
Yeah. Well, thanks for that question. I think one thing that was really notable to me that's not necessarily evident just looking at this graph was the pretty low stroke rate overall in this trial in both arms. And I think the overall stroke rate was about 1.5% or so, which is over 3 years, which is comparably low for an average CHADS VASC of 3.5, which was the mean in this trial. And I think there's a couple potential reasons for that that are worth exploring. One, as I mentioned before, is that there's some mounting data that perhaps AF ablation lowers stroke risk for patients. And all of the patients in this trial not only had the opportunity to be randomized to a left atrial appendage occlusion device, but also underwent AF ablation. So I think that's a piece of it here. Another piece of it is that perhaps by being part of a trial, the patients in the pharmacologic arm were more adherent with their anticoagulation than perhaps we see in the real world. I'll also note that in the device arm, about 10% of patients at the end of the study were also on anticoagulation. So there was a certain amount of belt and suspenders, if you will, in that group for various reasons, some of which was that patients were undergoing a second ablation and maybe were back on anticoagulation around that time. But that's another notable thing that these patients, if they did undergo a cardioversion or a second ablation, even after having the WATCHMAN device, they were put back on anticoagulation for the most part, I believe. Another thing that's interesting to me about this outcome is that again, in a way, this was sort of a real world study. They had many sites, and I don't think all the providers were super experienced with WATCHMAN. They had to have done at least a few, but I think after a roll-in of 2 or 3 patients, they were allowed to contribute results to this trial. And I think that's kind of reassuring, actually. Only about 80% of patients had a complete occlusion with the WATCHMAN device. And yet, they had, pretty good results here, as you can see, numerically equivalent, if not lower, than the anticoagulation arm with the curves superimposed. So I think this really is reassuring, both that this patient population had a low stroke rate overall, I think is interesting. I think it's reassuring in the sense that this device arm really did clearly do just as well as the anticoagulation arm. And as Megan has said, I think this gives us license to perhaps, think a little more broadly about putting patient preferences as a reasonable indication for thinking about this procedural approach.
You brought up a point that I think scares a lot of folks, and that is 80% closure at 1 year. people are saying, well, if you're doing this procedure at the same time, maybe there's some edema or swelling or bad humors or whatever it could be that doesn't allow us to understand how to place the device perfectly or assess it right after placement. But our field moves so fast and things change that it makes it hard to compare. So this study reflected real world practice and used CT instead of TEE as we had in the prior studies. And the leaks that were seen were tiny, but easier to see on CT. So it is hard to know if this outcome is different, if it's reflective of earlier operators. It is different from Pinnacle Flex, which was the first study that looked at WATCHMAN Flex amongst broad operators that showed, seals in the 90s. But you bring up the point, which is we're not treating patients to reduce leak and have seals. We're doing it to reduce bad outcomes of stroke and systemic embolism. And to your point, it's really low. And maybe it is the combination of less AFib from the ablation. Or maybe it's the patients who were included in the study. You talked about behavior with regards to adherence, but makes you wonder, we got the sense when you spoke before, these patients had paroxysmal AFib, it wasn't really complex ablation, so we start to wonder, were the patients very complex? So I was just going to pull up the characteristics of the patients at baseline in the study, and we can see they're, 70 years old, and you had mentioned their CHADS2-VASc was in the mid-threes. So they did have some comorbidities that put them at higher risk for stroke. So I would say they're not super young and healthy patients by any means. I think it's more ordinary patients in clinic. But they, are maybe leaning even towards more reflecting your VA population in terms of gender. We see that there's still not representation of women in the clinical trials. And although, the prevalence of AFib may be higher among men because women live longer, we have larger groups of women that have atrial fibrillation, and yet only a third. This is even lower than some of our prior WATCHMAN studies where we are starting to reach the 40% range. And I wondered if you had any thoughts. I know that in your patient population, you do serve a larger percentage of male patients, but does this give you any pause about how you think about the relevance of the results when you don't see representation of your patients with regards to, I should say, sex rather than gender? Because the question was, what was your sex assigned at birth? So we'll stick with that. So what are your thoughts about the applicability? And then we'll look closer at the race and ethnic makeup of the patients.
Yeah, no, I think we very much desire to have a good representation of women and other groups in trials, and the last decade or so have been really more focused on that as a medical community, and yet I think we still have a long way to go. And I think that there are real reasons to suspect differences. Women are smaller. They're more likely to have procedural complications. They often have a different type of heart failure. You might see more HFpEF than HFrEF in the female population, and that could lead to things being different. So I really do feel that it would be nice to have more representation of women as well as other groups. And I think that the more that that can be done, the less we're taking a leap of faith in our extrapolations. Obviously, we work with what we have and make do, but in an ideal world, of course, we would want that.
Yeah, I think for both you and I as scientists, this is not the best science that we could do if it's not reflective of the population that the device is designed to serve, and we could miss some really important scientific insights. We've seen that on the structural heart side with regards to TAVI. When we didn't include women in those studies, we missed a big understanding about how the valves function in smaller annuli, for example. But also just turning our attention to race and ethnicity. Now, this study, like many of our EP and IC trials, is global. And in many European countries, there's actually legislation that does not allow for collection of race and ethnicity data. So that's why you have 1 in 10 have it not disclosed. So that's okay. It was a lot. It was over 70 sites in the United States. So it's a big group of patients coming from the United States where we have a 40% minority population of racial and ethnic groups other than white, and we don't see anywhere near that. And we could talk a little bit about some of the race paradox in AFib, but still you still want some bigger numbers than this. And again, we've missed some really important insights, such as in renal denervation that we could have understood earlier if we had actually included the intended patient population that the devices were designed to serve. And you're right, it is a hot topic because the Food and Drug Administration has released its draft guidance for increasing representation in clinical trials with regards to age, sex, and race and ethnicity. So this will be more of a requirement. And one of the interesting things that the research shows is that consistently when you have more women cite PIs and on steering committees and as authors, we see an increase in that representation. And I think in this study, you and I had looked at the author list and the cite PIs, and there was maybe, out of hundreds. So I'm curious if you have some thoughts about how can we start to improve that we get everyone at the table for these research studies so that when we have this pretty remarkable result, we can think about how it applies to all of the patients we're trying to serve. What are some of the strategies or thoughts you have around that?
Yeah, I think that's a great question, and I will answer it. But first, I just want to pile on to what you said before with regard to race and ethnicity. And I just want to point out that sub-study of Cabana that looked at minority populations found that the discrepancy between outcomes with ablation versus drug was actually larger in the minority population, probably because the drug arm did particularly bad for many of those patients. And so it really, I think, is a sad kind of irony that the patients that are potentially at a higher likelihood of deriving a larger differential benefit are the least likely to get it. Similarly, there's been a lot of work looking at Asian population and risks with anticoagulation that I think might be even more pertinent here. And I think it would have been really nice to see a little bit larger population in this trial looking at outcomes for left atrial appendage occlusion, as I think there's a need to really have options for these patient populations. But moving back to your question about what are some strategies to think about improvement, I think the one thing is just the more that you measure, the better that you do. So I think having some standards, whether they're brought on by government, such as you mentioned in some countries, or adopted by industry, or something that societal groups such as the Heart Rhythm Society that I'm part of and do some advocacy work through, try and promote. I think by having goals and shared ideas about what we're aiming for, that will certainly do better in that regard. I think that speaking up and bonding together. So in the EP community, we have a group of women and are really lucky that some that have made it to the highest rung are not just sitting on their laurels, but are really trying to think about how can we, push to have more women in leadership positions. And I think that you're right that by having more women have a seat at the table, that will lead to a greater focus on more diversity in the patients that are being studied. I think this also comes up by including patients themselves and giving patients a seat at the table. I think that's another path to having trials more reflective of the patient populations that are relevant. And I think you and I both agree that that being patient-centric in this work is really important. I'm sure there's a lot more ideas, and I'm curious about what you also think are some strategies here.
Oh, I just love that you brought up the Cabana substudy. I'd kind of forgotten about that, that showed that Black patients specifically were more harmed by anticoagulation drugs and benefited from ablation. And here we have, 25 patients total from that race group to understand the benefit. I don't want to miss what could be something that could be really helpful to people. So I think part of it is us all looking at tables like this and looking at the discussion of this paper. Like, did they mention that? Or they discuss how they might do that differently? There was a big limitation around not including patients with EF less than 30%, but there wasn't discussion around this. So I think it's just raising the issue that we start to notice that, and that we can think about how we can make some of those changes going forward. And like you said, it's counting and accountability for sure. There's just one more slide I want to talk about, and that's this one, which is, we heard after the option trial, we won, we met our endpoints, and there's a lot of celebration. And the endpoint that they had prioritized was non-procedure related major bleeding or clinically relevant non-major bleeding. And both you and I, when we were discussing this, we had a lot of thoughts around these particular endpoints. And so I think people are wondering, if this is the win, is that enough for me to change my practice and refer someone who's never bled before to have a concomitant LAO and ablation, even though the study, a lot of them were, separated but close in time. And so I'd be curious to hear what your thoughts are when you look at this graph, especially the one that kind of blows it up here. And then you see a striking difference right in the first 3 months between the anticoagulation and the device group. But what are your thoughts about this as an outcome? Does it move you? And are there things you're excited about or maybe concerned about?
Yeah. So I think you and I had both picked two different things to hone in to have a little bit of a struggle with regard to this graph. For me, the primary thing that was bothering me was the fact that they chose to have the non-procedure related major bleeding as a portion of this endpoint. And I feel that it's a little bit unfair to have one arm get to close your eyes for 3 days after the procedure, the time when the worst outcomes are potentially going to be happening, and say, we're just not going to count any of those in one of these two arms. And the way that I always phrase this to patients is that, look, you're taking a small upfront risk for the longer term payout. Whereas in the other arm, you're dividing your risk more evenly over a longer period of time. And if you make it through this small upfront risk, you'll probably end up ahead. But I just don't think it's fair to completely ignore that this small upfront risk exists on one of these two arms in an unequal way. And so that was the piece that I found a little bit bothersome. Now, I will mention that in the secondary outcome, the secondary endpoint, they did look at major bleeding, including procedural bleeding, and found that the two arms were equivalent. So even when you do take into account that little bit of upfront procedural bleeding, given time, the two arms end up equivalent. And if anything, the device arm had numerically lower numbers, which begs the question for me, if you'd continue, have your magic wand and be able to have the funds and wherewithal to continue that study over time, would you see over time that the curves diverge further? Because again, you're taking that upfront risk, but potentially having less risk over time. So that was the first striking thing to me. Perhaps you want to talk about the clinically relevant non-major bleeding aspect.
Well, no matter what area of cardiology you're coming from, I think we can all notice that there are increasingly added endpoints and trials that are diverging from some of the what we used to call hard endpoints of stroke and death. And it's not a soft endpoint because this is exactly the reason clinically relevant non-major bleeding that our patients stop taking their anticoagulation. So I actually was really excited that this was included as an endpoint. It really wasn't in a lot of the earlier left atrial appendage occlusion trials. Major bleeding was the primary outcome. And so clinically relevant non-major bleeding is kind of a newer endpoint, just like heart failure events rather than hospitalizations is this newer endpoint in both heart failure and valvular heart disease. And this one is defined as patients are bleeding, but it's not enough for them to go to the ER for treatments, hospitalization. They're going to their doctor. They're having a face-to-face visit to talk about it. And we all have been there where patients come in and say, I was at lunch with my girlfriends and I had a nosebleed all over the plate. And I'm not going out like that again with them. It's embarrassing. So I'm going to stop my blood thinner. And you're in the office talking to them about this. This is clinically very relevant when they come to you with concerns about anticoagulation. And so those bleeding episodes, I think, are really important to count. Now, whether that is as important as reducing stroke and systemic embolism, well, Cara, to your point, This is so small, 1.5%. I mean, we do need to start looking at other outcomes. So I think this is a very patient-centered outcome. It's something that's really important to patients. And ultimately, because this therapy relies on people putting the pill in their mouth twice a day, we have to listen to patients about what's most important. So I do think there is a large group of patients out there that are at very high risk of non-adherence. I think 1 in 3 people who've never bled before. So I'm hopeful that data like this will help move the indications forward with left atrial appendage occlusion. Not to tell patients that they have to have a procedure, just to give them a choice so that they can pick what's most important to them. But we'll see. I think there's still a lot in both interventional cardiology and electrophysiology that are unsure about the therapy, that are wondering about the efficacy of ablation for stroke. So if you had to predict where we'll be in, let's say, 18 months, because policy changes don't go that fast, do you think we'll be waiting for more data to demonstrate the effectiveness of left atrial appendage occlusion in patients that are not currently approved for therapy? Or do you think this trial and some of the other observational studies we've seen will move us forward so there'll be the choices for patients?
Yeah, I mean, I think the last AFib guidelines that came out within the past year really did move up left atrial appendage occlusion. It's now a 2A indication and not just an option for patients who have had a major bleeding event. It still has a space in the guidelines for patients who are choosing it. So I think that change is already in process to my mind. And I think that what this trial does, the biggest contribution that I see is suggesting that that safety of concomitant procedures is pretty good, and that even with small leaks, even with some of those concerns around doing these procedures at the same time, you still can get there. I think with an electrophysiology eye, that it also is just kind of further suggesting, look how low these stroke rates are, and maybe will even prompt at the edges there of the lower CHAS-VAS score, could we even think about not doing anything for these patients? That's another direction that I think many in our community are wondering about is, with patients wearing more monitors and therefore being alerted when the AF does come back, could we be thinking more about a pill in the pocket strategy for some slice of patients? So not to get too far from the option trial, but I think that that's another space of inquiry. But yes, I think with regard to left atrial appendage occlusion, I think that this trial is going to open up a little bit more of the door to doing these procedures at the same time and feeling good about safety, feeling good about getting adequate seal such that the stroke rates are still equivalent, and the clinically relevant non-major bleeding piece. I think for many of us who are on the front lines taking care of patients that having these nosebleeds, as you mentioned, or these minor GI bleeds or blood in the urine, these things are real and a true reason that patients really will be dissatisfied and constantly bringing up, when can I stop this medication? And so it's nice to recognize that we really do have an option for them.
And I think this strategy of having interventional cardiology and electrophysiology continuing to be involved in left atrial appendage occlusion is so important. I know at your institution, you're partnering side by side in the procedure. And at the same time, as things get busier and busier and there's a greater need, we may not always be able to do that, but to be in conversation like we are today and to think about how we can make sure that we're partnering to offer all the options to patients to reduce the risk of stroke. I know one thing that I feel for certain is that there's going to be way more patients with AFib that are going to need help with these procedures than there are physicians. So it'll be all hands on deck from both interventional and electrophysiology. And I think we'll be able to continue to build, as you have at your institution, programs that are multidisciplinary that can figure out how we can meet the community needs together in a way to improve patient outcomes. So, Cara, thank you for your leadership in electrophysiology and especially as a left atrial appendage occlusion operator. And your insights were really helpful today to have us think critically about this study and how we might apply it in practice.
It's my pleasure, Megan. Thank you for all the teaching that you do. I think you are extremely thoughtful and are asking some really great questions. And I think that that's really important for us to not just accept what we find, but really inquire and try and make better. And it's been such a pleasure talking with you.
All right. And thank you all for joining us.